Go ahead, ma'am.
Good afternoon, everyone. Myself, Dr. Kanchan Durugkar. I welcome you all for our another Facebook Live session. And today, our Facebook Live session is about what is new in the treatment of male infertility. So today, we are going to focus about what are the causes, in short, about male infertility, and what are the treatments options that are available in the treatment of male infertility. So, dear friends, I welcome you for this today's Facebook Live session. So, first of all, we will see what are the we know, as we all know, with so much of discussions that around in the causes of infertility, around 40 to 50% of the causes are related to uh, male partner. So what are these causes of male infertility that can lead to infertility? So these can be related to semen parameters. So first and the foremost investigation that we do in the cases of male infertility is semen analysis. So semen related problem, like low sperm count, that we call it as oligospermia, and motility related problems, that is we call as astenospermia, and morphology related, that is normal shape of the sperm is not there, that is we call as a teratozoospermias. And all these problems, all these three problems can coexist, that we call as an oligoastenoteratozoospermia, that is we call as a oats. Then other problems can be complete no zero sperm counts, that is called as a azoospermia. So that can also be a problem of infertility. So other semen related problems are more common. Other sexual dysfunction related problems can also be there, that can lead to infertility, like erectile dysfunction or retrograde ejaculation. So these are the other problems which can lead to infertility. Now, what are the treatment options available? First of all, we will discuss about low sperm count. Now, when we label it as low sperm count, so when according to the recent guidelines, 2020 WHO guidelines, if the sperm count is less than 16 million, motility is less than 32%, and normal morphology, that is normal sperms, if they are less than 4%, then we call it as a abnormal semen parameters. Now in this, if the count is low, means less than 10 million, we'll say, then it is called oligospermia. Actually less than 16 million is oligo. Then uh, motility and morphology I talked of, that less than 32% progressive motility, that is the grade 3 and grade 4 we call them, that is the rapidly progressive and progressive sperms that are more important for fertilization, so that should be more than 32%. And morphology also should be more than 4%. So if these parameters are deranged, then it is a we will say as oligoastanoteratozoospermia. Then there can be various reasons for this, oats or oligoastanoteratozoospermia. So what can be these reasons? These reasons can be, depending upon the patient's BMI, like obese patient, obese, obese male partner, or addiction related problem like smoking, alcoholism. Then other genetic problem also can be there, which can lead to oligozoospermia. Then varicocele problem, that can also lead to this uh, low sperm count. Now, what are the treatment option available for, and how should we go ahead? How to know what is the reason for this low sperm count? So, low sperm count, for this basic, we do the investigations like semen parameter, semensis, that we do in the detail if at all it is done. Then we repeat it. If only one sample of um, oats is there, then we should actually repeat the sample after 6 weeks, and we should see if the same finding or is there, or whether the abstinence was there or not. So always there should be a recheck. Then what can be the reason? So semen analysis, if at all it is second sample is also showing low sperm count, then in that case hormone testing in the form of testosterone level, then FSH level, thyroid level, prolactin level we check for. We see for the USG scrotum whether there is any varicocele or any other abnormalities like undescended testes or any other problem if there are. Then we see also for the genetic testing in the form of karyotype. So these are the various investigations that we do for the patients with low sperm count. Now, if at all we see that the count is all the parameters or the tests are normal. So in these patients, we should actually, if the count is low, like if it is less than 5 million and less. So in these patients, we should opt for is IVF treatment or ICSI treatment. We to be very specific. And why the ICSI treatment is helpful in this patient and why not IUI? Because the low sperm count and low motility will not give us success in the IUI treatment. So these patients can have successful pregnancy outcome with the help of ICSI. Now, what is ICSI? ICSI is a procedure in which we have to do the stimulation of the female partner. We have to retrieve the eggs, and then the injection of the sperm. That is, this is the under IVF a microscopic procedure. It is done carried out in the IVF lab. The egg or the human oocyte is injected or inseminated with the sperm, good quality sperm, that is called ICSI. So ICSI is very, very useful. Actually, the ICSI was invented for the patients with less sperm count or less than 5 million sperm count. So now it is a routine recommendations for the patients with oligoestano teratospermia. For these patients, ICSI is a very, very useful procedure because it gives a good fertilization rate and successful pregnancy outcome in the patients with low sperm count. Now, in the patients with low sperm count, the morphology is also deranged. Their normal shape of the sperm is also not at the optimum. So in these patients, some sperm selection technique also we can do. At Oasis also we do routinely this sperm selection technique, which can help us in selecting a healthy sperm for doing XC. Now, what are these sperm selection techniques that we can do? These are MAX, that is magnetic assisted cell sorting, or microfluidics. So these techniques, have their different mechanism of actions. Like MAX or magnetic assisted cell sorting uses magnetic field to, uh, select to scrutinize the denaturated sperm and the healthy sperm we get in the pellet, and these healthy sperms can be used for doing ICSI, and this is very useful procedure in the patients with severe OATS or with the low sperm counts. Also, MAX is useful in the patients with raised DFI, where the DNA fragmentation index, or we will say that denaturated sperm or dead sperms are more. In those patients, MAX is very useful procedure because we can select a healthy sperm. Denaturated or fragmented sperms can be separated, and we can do the ICSI or the IVF procedures, or mainly ICSI procedure, with the healthy sperms, and we can get a good quality embryos and a good successful pregnancy outcome. So this is about the MAX. Then microfluidics is also one sperm selection technique. In microfluidics, what we do is we use the wells where the semen is put in the one well and culture medias are put in the two different wells, and the motile sperm, which is having the good motility, will be traveling to the one of the well. So this good motile sperm will be selected and the ICSI will be done with that sperm. So this is about the microfluidics. So these two sperm selection techniques can be used. Other sperm selection techniques are also available. That is PIXI, where the high resolution camera, high resolution microscope can be used to select for the good morphology sperms. Then that good morphology sperms can be used to do the ICSI. And these procedure will improve our ICSI fertilization rate and embryo formation and pregnancy rate also. So these sperm selection techniques are very useful in the patients with low sperm count. Now coming to the patients with zero sperm count. Now, first of all, we need to look for why there is zero sperm count. Semen production is there. Semen volume is also normal, but the semen doesn't contain any sperm. That is called azoospermia. Now, why there is azoospermia? There can be multiple reasons. We'll not go into the details of causes, but I will come to the most common cause, that is obstructive forms. Now, in obstructive azoospermia, which we encounter in almost 60-65% of the cases, where the sperm production is happening inside the testes, but they are not coming out. Okay, so there can be multiple reasons, genetic reasons, some of infection related reason can be there, n numbers of reason can be there for obstructive azoospermia. But the outcome of obstructive azoospermia is very good. We can do the sperm retrieval techniques. Okay, so sperm surgically we can retrieve the sperms. This is done under anesthesia. This surgical retrieval of sperm is under anesthesia procedure. It is a short procedure, and we can successfully retrieve the sperms in the patients with zero sperm count also, with the advent of recent sperm retrieval techniques like TISA, that is testicular sperm aspiration, or microtessay, where the microscopic, you know, evaluation of the testes is done, and we can find out the areas where the sperm production is happening, and from there we can retrieve the sperm and sperm, testicular tissue, and the sperm sorting can be done from that, and those sperms can be used for ICSI. So these surgical sperm retrieval techniques you, can help us in having the embryos of our own gametes, of our own sperms, in patients with even no sperms or zero sperm in their semen. So in the patients with azoospermia, we have successfully achieved the pregnancies with TISA and microtessay also. So microtessay is a little advanced technique for the patients with non-obstructive azoospermia. Non-obstructive, I mean that there is no obstruction actually, but there is a problem at the level of testes only, where the sperm production is not happening at the optimum. There is some problem in the testicular tissue. So these patients generally have some difficulties in having conception or in having embryos of their own sperms. So in the non-obstructive azoospermia, microtessay, this is a microsurgical sperm retrieval technique in which the microscopic, we scan for the areas in the testicular tissue where the sperm production is occurring, and from there we can retrieve the sperm and use it for the ICSI procedure. So that is called microtessay. It is also one of the recent advents that is used in the patients with non-obstructive azoospermia, or the patients where there is some testicular pathology for which has hampered the sperm production. Now, coming to the patients with hypogonadotropic hypogonadism. Now, these are the small subset of patient actually. They will they are the patient with azoospermia, means zero sperm count, but there is a problem at the level of a brain. So the signals from the brain are not there to form the sperms. So this is called as a hypogonadotropic hypogonadism, and these patients do have some genetic problems, but it is the most treatable form of azoospermia, I will say, as because in these patients, even with the help of medical treatment, that is in the form of tablets and gonadotropins. Gonadotropins, in the sense, these are the hormone injections that we give to the male partner in the weekly basis or bi-weekly basis, okay, for the patients of hypogonadotropic hypogonadism, and they can have normal sperm count, and they can conceive naturally also. So it is a, though the duration of treatment for this hypogonadotropic hypogonadism is long, that is 1.5 years, 1 year to 1.5 years may be required depending upon the patient's response, but definitely these patients can achieve the pregnancy. Even a natural conception is possible in these patients. Now, this is about the azoospermia. So these are the different types of azoospermia and the treatment likewise. So treatment depends upon the what type of azoospermia is there, but it is not the thing that the patients with azoospermia are having only an option of donor sperms. Even the patients with non-obstructive azoospermia can have a chance of having their own sperms, and they can have the chance of having the pregnancy, clinical pregnancy of their own gametes. So this is about the azoospermia. Now coming to some recent advents that have come up, that I will tell about is the PGTA or PGT, that is a pre-implantation genetic diagnosis for aneuploidy. So this is the recent advance that has come, where we can check the embryos in the patients with recurrent implantation failure and recurrent pregnancy loss, where the male factor was also involved. Like if the male factor was like raised DFI or low sperm count, and that has lead to implantation failure or maybe recurrent pregnancy loss. So in that patients, embryos can be tested for any problem, if at all the embryos are having, and accordingly, or if at all any structural rearrangement is there, like if any genetic problem is there, like balanced translocation or any other single gene defect are also there, so they can be tested and they can be addressed likewise by PGTM or PGT. For monogenic disorder we can do PGTM, and for structural rearrangement we can do PGT-SR, and for aneuploidies, like in the patients with recurrent implantation failure or recurrent pregnancy loss, we can do is PGTA. So these are also recent advances available where we can test the embryo itself, and then we, after testing, after knowing that that embryo is normal, then we can do the embryo transfer, and definitely it can improve the success rate for the couples who are facing recurrent pregnancy loss or recurrent implantation failure or maybe raised EFI. Then coming to some other recent advances that I will just mention. So I will mention about sperm VD. Sperm VD is where you can where we can freeze even 1 to 2 sperms. That is it is called sperm vitrification device, where single sperm, or the sperms which are which can be counted in numbers, can also be frozen and can be used further for ICSI. So the sperms that are retrieved by microtessay, like the microsurgical extraction we have done, and we have got the very few sperms, like 4 to 5 sperms if we have got, then those can also be vitrified. And these are the new this is the new technology available, that is called sperm VD, that is sperm vitrification device. Then where you can actually freeze this the 4 to 5 sperms also, in 1 to 2 sperms also can be frozen. Now coming to one more advent, that is testicular PRP. This is there is a recent paper coming up in September 2021, where the testicular PRP, that is PRP is a platelet rich plasma. It can be injected in the testis, and after 3 months microsurgical tessay can be done, and the successful testicular sperm aspiration was achieved in 10% of the patient in whom first microtessay was failed. So these recent papers are coming up for the recent studies, that testicular PRP for the patient with non-obstructive azoospermia who have failed microsurgical testing. In this, the patients testicular PRP or testicular stem cells are giving promising results, who are left with the option of donor sperms, or they don't want to go with the donor sperms. In these patients, these testicular PRP option is coming up for the patients with non-obstructive azoospermia, failed microtisa also. And though the success rate is not that promising, but still some patients, like 10% I will say, have received a successful outcome, or successful sperm retrieval was done after testicular PRP. So these are the recent advances which I wanted to discuss today. Recent studies are going on for the patients who had uh, previously medical science didn't had answer for those problems, like earlier, even for the patients with you know uh, urinary or post ejaculate urine have now can we can have them successful outcome with TISA. Then other patients with non-obstructive azoospermia and obstructive azoospermia, they can have a successful outcome. Even the reconstruction surgeries are possible for the patients with uh, you know uh, obstructive azoospermia. So in those patients, uh, the reconstruction surgeries can give the successful pregnancy outcome. Also, for the patients with grade 3 and grade 4 varicoses, these patients varicocelectomy can be done, and the sperm count and DFI can be improved with varicocelectomy. So these are the recent surgical interventions that we can do. Some medical interventions are also there, and some sperm selection techniques are also there. So these are the recent advents that have come up in the patients with male infertility, and in those problems which were unaddressed or which were not solved by medical science, those also are solved, and the pregnancy outcome, successful pregnancy outcome, and a good healthy live birth can be given to those couples struggling with the infertility problems. So that's all from my side. If at all any questions the viewers are having, they can come up with the questions. Thank you from my side. What is the best treatment for male infertility is the question coming up. So best treatment that I would say will depend upon the cause of male infertility. What is the cause? So with or what is the, and accordingly the treatment can be planned. So depending upon whether it is a low sperm count, or whether it is a zero sperm count, or whether it is a sexual dysfunction, so that needs to be addressed, and according to the treatment can be given. If it is a low sperm count, we can think of the sperm selection techniques and ICSI, and in the patients with azoospermia, we can is the sperm retrieval techniques in the form of TISA, microtese. Okay, so what are some of the new technologies that we have, is been asked? So as I mentioned in my this session, that there are new technologies coming up, like the TISA was the only technique available for surgical retrieval. Now micro TISA is also available for the patients with non-obstructive azoospermia, where we can you know uh, we can scan for the areas of spermatogenesis, and from there we can retrieve the sperms. That is a surgical sperm retrieval technique. It has some time duration of that surgery is somewhat long, but for the patients with non-obstructive azoospermia, yes, it is a promising technique, microtase. And other techniques I have also talked about, like sperm PD, where we can freeze even 2 to 3 sperms that are retrieved from microtase. Also, I have talked about testicular PRP for the patient with non-obstructive spermia, non-obstructive azoospermia. Papers are coming up where they have got a successful sperm retrieval after uh, testicular PRP. Yes, but the broad spectrum studies are required for these procedures to become more, common. But yes, the positive results are there with testicular PRP. which infertility technique has highest success rate. So earlier what was done was IVF. Okay, so in IVF, what was done is the human egg was kept in a petri dish, and around it was kept the sperms. So and the fertilization was watched for. So in these patients, sometimes the fertilization failure was seen, and fertilization rate was actually lower as compared to the newer technique, that is ICSI, that has come up. In ICSI, what we do is we inject the or inseminate the human sperm into the oocyte. So that ICSI technique can help us in the fertilization. Also, in the patients with low sperm count, it can help to get the fertilization and good embryo formation, and hence the successful pregnancy outcome. What percentage of infertility is cured? So what percentage, I will say, maybe we have success rate of 60 to 70%. So that depends upon the what are the causes the patient is having. So whether it is a single cause or the multiple cause, or male and female both are having some other issues, so that needs to be addressed, and accordingly we can say that how much can be a success rate for that couple. And depending upon even a female evaluation, and complete evaluation of the couple is important, and accordingly we can say that it can be good. But yes, there are solutions to the problem, most of them. And 60 to 70% success rate we can say for the patients who are undergoing IVF with the recent advents that have come up. Okay, so how do we know that we are infertile male? So this is a very important question, that how a male partner know that there is infertility because of them only. So if at all you are trying for conception since 1 year with the natural intercourse, unprotected intercourse, and still the couple is not able to conceive, then there is some problem. The couple needs evaluation, you need evaluation. And only test that is generally done as a primary checkup is a semen analysis. It's a very important test. Abstinence is very important, like 48 hours to 7 days of abstinence is required. And if at all that abstinence is there, then semen analysis has to be done. And in semen analysis, we see for the parameters like sperm count, sperm motility, and morphology. And if at all these are normal, then the um, male partner is having no problem, like semen analysis related problem are not there. Or if at all there is a count related problem, like low sperm count or motility related problems are there, then they can be find out by doing just a simple test, that is a semen analysis. Okay, we'll wait for 2 3 more minutes for if at all any questions are there from our viewers. Then we'll close the session. Okay, I think that's all from the question answer side also. So I thank all my viewers. If at all any consultations are required, our helpline numbers are there flashing on your screen. And if at all physical consultations are required, our centers are in Oasis Fertility, Pune, in Vakar, and in Kharadi. So do come up with your queries. We are here to help you, and best of luck. Thank you.